So good morning, everyone. I would like to talk today about use of augmented reality as well as mixed and virtual realities in the field of spine surgery and how it can correlate to the drive for the minimally invasiveness of the procedures. Here are my disclosures. So the actual concept of minimally invasive spine surgery, it's not just the site of the incision. There are many systems involved, and I hope everyone recognizes that any procedure puts a strain on those systems. So when we talk about minimal invasive surgery, we do take into consideration other organ systems as well. In general, of course, exposure matters, but it's only a part of the component of what invasiveness is. How much patient's anatomy is changed is a big component as well. And time, how long it takes, is also very important. You would agree that doing a microdiscectomy for 6 hours is not really that minimally invasive anymore. So time is very important to consider when creating a plan for a minimally invasive procedure. Over the years, of course, spine surgeons, neurosurgeons, and every surgery field in general tries to perform their surgery in the least invasive fashion possible. And so that created this multi-billion-dollar industry with all kinds of equipments, navigation systems, fluoro machines, O-arm, and all these systems are now in our operating rooms, occupying space. Many of the buildings are from 1950s, with the rooms are being very little, so you can imagine walking around the tight space in the OR. So now we have this overburden of equipment, multiple screens, and you can see the middle picture demonstrating constantly looking at the screen away from the surgeon. Does that create an issue? And can the augmented reality or mixed reality technology facilitate and bring it all back together? We could also consider how invasive the surgery is on the actual surgeon. We've looked at radiation exposure, we've looked at posture of a surgeon. All of that matters. We all try to be productive for as long as possible, but of course, being in a certain slouched over position, exposed to radiation, overusing our hand joints and other joints can significantly reduce our ability to have a productive career over a long time. Can augmented reality be used as well to facilitate that? Well, let's see. But what are all these realities, right? So virtual reality, I think, has been around a little longer and it's a little more easier to understand. A user is usually wearing an enclosed goggle space, not seeing anything around him, and usually just happening in the digital world where different actions can be performed. So that's virtual reality. And now we have a concept of augmented reality where you can see the world around you and digital images are superimposed onto real objects and kind of interactive with the real world. And then the mixed reality, it's still a loose term and people use augmented reality, mixed reality, still loosely and not very well defined. But in the mixed reality is when you have the object overlaying the real world and it's a digital object, and it can also be immersive and interactive. So you can have a user manipulate components, like you have a picture of this turbine engine sitting on the real table where an engineer can now try different components in digital world before building a prototype, thus saving time and cost. What can we use these systems for in spine surgery? And here are some of the points that I would like to make, and we're going to go one by one over them. So the education. Big component, right? If you think about traditionally, it's always been an apprenticeship model where you follow a surgeon, you watch the surgeries, and then you pretty much practice a lot of times life during surgery. And of course, cadaver labs are important. And can digital world replace some of the costs and some of the time? It's still yet to be figured out. Here we have Dr. Steinberger from Mount Sinai demonstrating a lateral mass screw placement to a student through a virtual reality. Probably a good use for anatomy learning, initial introduction. Can that translate to physical world? To be figured out. We have Dr. Uribe from his recent publication showing how they use virtual reality to train in spine surgery as well, using the instruments, using the different directions for placement of the pedicle screws. Of course, that sounds all great. A lot of times the downside of it still is the cost. To establish a virtual reality system for education purposes still with existing technologies currently would probably be in the 6-figure price range, which for any GME budget still on the tight stretch. So now the costs are being offset by how much really it is useful. And also a lot of residency programs for training and fellowships are usually busy. So finding that extra time is also another thing that needs to be considered. So you don't want to buy a system and then just let it sit in the corner because no one has time to use it. This is the picture of how, I guess, a lot of clinic interactions are happening. You have a doctor, a patient sitting at the desk, looking at the computer, maybe sometimes reviewing the images. Here's a picture from 100 years prior of a doctor consultation viewed by a hand solution. And you can see not much really changed. It's the same type of interaction. And especially in spine world, where we demonstrate the images, MRIs, CAT scan. And to patients, it's just 50 shades of gray, right? A lot of times after 15 minutes of looking at their images, they go, is that a butterfly there? So you know they're not really getting it. Adding an augmented reality, a 3D holographic image of a patient-specific anatomy, facilitate that discussion, improve it, make it faster, make it easier to understand? Possibly. Here's one picture of how I use it with a 14-year-old gentleman who has a juvenile scoliosis, has seen the plain films. They're from South America, has seen the printed out plain films that you have to put up to light, and kind of knows he has a curve. We've loaded his scans into 3D, and you should have just seen his face. He was like, oh, wow, so that's what I have right now. He was looking at his spine in 3D, walking around, really looking at each segment and understanding of what exactly is going on with him. And just, you know, both his mom and himself are here in the pictures, and they were just amazed by what they were able to appreciate. Surgical planning, visualizing complex anatomy in 3D space before you go into surgery. Here's a demonstration of a complex construct. And there are different views, of course, on the video, and you can see with the slider, a different windowing appears, allowing to see more bone, more soft tissue. So that preoperative surgical planning can be important, especially when considering minimally invasive approach where you're not going to be able to see the anatomy as well. So visualizing the 3D prior to surgery can help understand how the hands should be, where the position is, where the starting point is, and which tissues are being traversed. Intraoperative, preoperative planning is also important. You all know those elusive thoracic levels where you don't know whether to count from the top, from the bottom, either a traditional level, either 11 ribs, 13 ribs. All of that has to be taken into account. And here's the video demonstrating. It's a little choppy because, as you can imagine, trying to record a 3D rendition probably overburdens the computer system. So that's why it looks like that. But to a viewer at that time, it's pretty smooth. So a level digitally identified before, superimposed onto a patient, and now you can see the green line showing where the target for the surgery is, and easier for planning. In that particular video, we correlated that with an X-ray fluoroscopy, and there was one-to-one correlation, made it very easy. More demonstrating pictures on the left of how that may look intraoperatively, both cervical localization in the middle and lumbar localization. On the lower left, you can see the two needles traversing the prepped patient, so you don't really see the spine, but there's a digital image superimposed that shows the levels, and the right fluoro image corresponds and correlates those needles to actually what was seen. So the number of poking is done, the number of X-ray done is much less. Now for the actual meat of the technology, right? We want to use it in the OR. We want it to be useful, such a way where it helps speed up the surgery, helps make it less invasive, safer, while maintaining all of the gold standards that are currently existing. Back in 2018, we demonstrated in the cadaver lab using augmented reality and percutaneous placement of the screws. At the time, there was no navigation, and we learned real fast that without actual feedback loop closed in where the instruments are and where the patient is, that may not be still as reliable by simply overlaying the image. So for the next session, we've used the 3D navigation system incorporated with the augmented reality. So now seeing the spine and correlating the images with the model as well as an instrument. And to demonstrate that pretty much any instrument could be connected by using simple 3D printed adapters, was making the system far more accessible than what some people may believe. All of a sudden, not as exclusive, and it's really easy integration, and more or less very easy transition from what we used to with navigation system. Currently, we're working with Magic Leap. It's a different type of a goggle system, of course, to create a system that would allow us to visualize that same views as you saw prior, have them navigated, have instruments loop in and feedback as well. So we have all of those integrated and allow us to really perform that same surgery, but much safer. And also keep in mind the line of sight. You can see how the surgeon here holding the instrument is looking still at the patient, not away at the screen. So the hand adjustments are much faster, and you don't really lose that sway when you change the head positions. Currently, if you look around for literature, there are a lot of papers on the cadaver studies, unofficial labs, and even more, all types of reviews about what augmented reality is, but really just a single clinical paper, and that's the initial experience from Dr. Shuba's group by using augmented reality. And this is a head-mounted display system in real life surgery with instrumentation. This creates, as you can imagine, a big open field of untapped opportunities. Still a lot of clinical investigations to be done. And as we know, there's just one system right now that's available for intraoperative use of augmented reality, but many more are currently in FDA clearance process. Well, you don't really have to have the whole functionality of augmented reality where you see the 3D hologram superimposed onto the spine. You can utilize the function of a heads-up display of added information in front of your eyes so that you don't have to look away. There are some of the pictures demonstrating that. On the right at the top, looking the way of the screen, performing a cervical operation, while on the bottom, having everything in line of sight, looking at the neck, seeing the structures, placing the inner body cage, and not being distracted. So use of heads-up display function can also be an intermediary step, but also an easier step, maybe even a cheaper step. So people don't just think that it's all about 3D holographic images. We've incorporated heads-up display into endoscopic surgery, which allows us the same thing in terms of inline line of sight and using the hands and operating and seeing how the hands move. Appears so far, anecdotal level, interact better with the surgeon. Here's a demonstration of placing a lateral percutaneous screw with a heads-up display demonstrating how the navigation system, which is standard stealth navigation system, can be projected in the surgeon's direct line of sight. So here you can see the surgeon does not have to look away as the screw is being placed. And again, it just helps with keeping the hands in line, not doing those extra moves, not wasting time looking away. And a lot of times those screens are in an awkward position anyway. So this makes the surgery much easier. Back to the question of can AR help a surgeon maintain their longevity as well? In the academic institutions, we're lucky enough to be assisted by highly motivated, excellent trainees, fellows, and residents who are eager about surgery. So you can trust them with some of the steps. But at the same time, as the rise of single-stage surgery is coming, and now we're performing simultaneously interbody lateral decompression or exposure and percutaneous screw placement, I still would like to be in control of that part. So I can actually wear my heads-up display during the single-stage procedure to keep an eye on what my assistant is doing in terms of where the screws are going, while not really looking around at the same screen they're looking for navigation. So that's another way to consider using the heads-up display. And so for the most part, you want the augmented reality system to be affordable, at the same time, not overbearing in terms of how much extra time it requires to incorporate. It should be helpful. It should help with allowing us to perform the surgery safer with the least invasiveness factor. And the transition should also be smooth. So last year we talked about old dogs learning the new tricks, and it is really a technology that's not going to be very easy to initially accept. But I think over time, as more and more people get involved and they'll see the use of it, it will be more popular. Thank you.
Timur, can you hear me okay? Thanks for that awesome talk. I really enjoyed that. You've been developing this so nicely the last couple of days, a couple of years. It was fun to follow you. And I think you really bring, planning your surgery on a sofa to a new sort of, it was nice to be able to see where you plan your surgeries right on the sofa. But where do you see the implication for this technology, not only for the surgeon, but for the rest of the OR team? As you know, we typically know what the next step is going to be, but you work as a team, as you mentioned. And I saw in your picture that you had the goggles on, but not your poor assistant who was kind of like, had no idea where you were. And so how do you plan to integrate that, with the co-surgeons, with the scrub tech, with the circulator? I mean, wouldn't that be a great opportunity to bring efficiency into the system?
And it's all in the works. It's just a matter of computing power and getting all the coding done. Of course, the currently accepted system that's FDA approved does allow two headsets at the same time, so both the surgeon and the assistant can use that. But you bring up a very good point. Do you visualize the future OR where everybody in the operating room is wearing some kind of a heads-up display, some kind of a smart goggles with information in front of them, so that the information flow can be much faster and more efficient? Absolutely. Still sounds very sci-fi and futuristic, but I think it's not that far.
Timur, that was a great talk. What do you think the limitations are right now of that technology? Where do you think it has to go before it becomes kind of mainstream?
The limitation of technology. So computing power. Any goggles you put on, and you expect this perfect world, you still have to have some expectation that there will be a lag, a delay. Your head motions should not be as fast probably as you're usually used to. And then it takes some time to get used to that kind of digital superimposed world, because it doesn't, while you can see it and superimpose on a real person, as you move around, the computers are still lagging behind a little bit. There's a lot of communication between the external visualization platforms, and the information has to come into the headset. The headset should be light enough, not too heavy, so you can't really pack too much technology into it, which can be, of course, remedied by having like a wearable backpack or some kind of a external pack that you can wear somewhere else. But those are the main limitations right now in terms of technology itself. Of course, cost and getting people that are already used to current use of navigation systems, fluoro, freehand technique, to convince them that all of a sudden now you should wear those goggles. That transition is also going to be challenging.
Timur, great talk, but quick question. What is the cost right now? I mean, I know there's at least one company that produces a product that you could certainly get now, but do you have any idea about the cost and whether it'll change?
So relatively, and if you can trust the system, the costs are actually very competitive. So if you think of a standard stealth navigation system, to acquire, it will be close to 7-figure for the hospital. And it seems that with the head-mounted augmented reality systems, within a 6-figure range, you can get a system going, which is really a fraction of a navigation system. And also keep in mind the compact factor of it. You can really pack it in a suitcase and take it anywhere, while the usual navigation systems are much more bulky.
So you have to integrate it with an existing navigation system, or am I mistaken? So you do need a navigation system in place. This is an add-on or not?
Well, in the talk, I demonstrated various use that we've tried to kind of combine things, and that using the heads-up display with navigation system. That was a demonstration. But the augmented reality system on the market right now does not require you having a stealth eyes and the whole tower. It's a standalone system in itself, and the goggles have everything you need for the 3D tracking.
Great. That was a fantastic talk. Thank you.
My pleasure.